So, hello everyone. So, today we are going to study a very important topic newborn resuscitation. It is very important in pediatrics, neonatology, etc. So, it is an emergency condition also. So, introduction. So, in 6 month, around 6 month, newborn die every year in India, and out of this, 19% of these are attributed to birth asphyxia. The term asphyxia, we all know that it is the inability of a newborn baby to establish optimum respiration after birth, and this asphyxia can lead to progressive hypoxia, then hypercapnia, increase in carbon dioxide concentration, hyperperfusion, lesser tissue perfusion, and also acidosis. So it may often lead to multi-organ failure, and also one condition, neurological condition called as hypoxic ischemic encephalopathy, which results from asphyxia, may lead to long-term neuromotor sequelae. According to AHA and AAP recommendation, 85% of all neonate are term gestation and do not require resuscitation. So 85% of these children are like term birth, so they do not require resuscitation. So, but around 10% of neonates require initial steps of drying and stimulation. In stimulation, what we do is that we tap on the on the back of the baby, or the sole of the foot of the baby. So it shouldn't be vigorous also. That is stimulation and also drying. But the rest 5% require positive pressure ventilation at birth. So out of 85% of newborns are term birth, they do not require a resuscitation, but 10% require drying and stimulation, and the rest 5% are the newborns which require PPV at the birth. Primary apnea. So what is primary apnea? So fetus, if he or she is having decreased oxygen, there will be brief period of, due to obstruction, due to various reasons, if he or she is not able to breathe, there will be a brief period of rapid breathing. If asphyxia continues, there will be respiratory movement ceasing, and which leads to the primary apnea. And during the primary apnea, the heart rate begins to fall, the neuromuscular tone diminishes, but the blood pressure is preserved. Note, in primary apnea, the blood pressure is preserved. And mostly tactile stimulation reinitiate respiration. So tactile stimulation, I already said, that is rubbing on the sole of the foot, or like tapping or just slightly beating on the, not beating, just rubbing on the back of the back of the baby, back of the chest, will help in reinitiating the respiration if it is only primary apnea. And it is an important point, that is blood pressure is preserved in primary apnea, but heart rate and neuromuscular tone diminishes. And next is secondary apnea. So if the asphyxia continues further, there will be deep gasping respiration, that is irregular type of respiration, and heart rate continues to fall. Here the blood pressure also decreases, and the infant becomes flaccid, that is neuromuscular tone further diminishes and the baby becomes flaccid. The fetus is now unresponsive to stimulation and does not spontaneously resume respiration unless positive pressure ventilation is initiated. So here occurs a stage where we need to initiate the PPV, only then the respiration is reinitiated, because the baby will be unresponsive to the tactile stimulations. Apnea at birth may be primary or secondary apnea. When faced with an apneic infant at birth, assumes as secondary apnea and institute full resuscitation. That is, primary and secondary apnea are similar in clinical features. So whenever the baby is in apnea, consider it as secondary apnea and do the emergency or the necessary things. And about lung inflation. So during the intrauterine life, the gaseous exchange occurs through the placenta, right? Yes. So the lung alveoli will be filled with fluid by the type 2 alveolar cells. So the fluid removal at the time of intrauterine life, okay. So the fluid removal takes place at the onset of labor. The first few breaths after the birth effectively expands the alveoli and replaces the fluid with air. And the problem in clearing the lung fluid That is apnea at birth, weak initial respiratory efforts, as with prematurity or sedation. So, problem in clearing lung fluid occurs to whom? That is, if the baby is having apnea at birth, there will be a problem in clearing the lung fluid. Or if the baby has a weak initial respiratory effort, as in prematurity, or the baby is in sedation. So these all the things where the lung inflation problems occur and the baby goes into primary and secondary apnea. So, talking about the pulmonary circulation, the asphyxiated infant, that is like hypoxemia, acidosis, falling of pulmonary vasodilation, and closure of ductus arteriosus. So, these are the causes of asphyxiated infants. And mildly asphyxiated neonates restoring ventilation, it increases pulmonary blood flow. And severely asphyxiated infants, oxygenation plus correction of acidosis improves the pulmonary blood flow. So that is about pulmonary circulation. Circulation. Asphyxia redistributes the blood flow from the non-vital to the vital organs, and the blood flow to the heart and the brain is relatively preserved. As asphyxia is prolonged, the myocardial functions and the cardiac output deteriorates, and the blood flow to all the organs is further reduced. So, in asphyxia, what happens? The body is alerted, right? Yes. So, it redistributes the blood flow to only to the vital organs. So, that is the brain and the heart, right? If it is further continued, what happens? These two organs also will lack the oxygenation, and the baby will he or she will be having conditions with myocardial functions, and also the cardiac output deteriorates and the blood flow to all the organs is further reduced. Preparation for delivery. So, they inquire about the antepartum and the intrapartum risk factors, anticipate emergencies, and plan accordingly. The team leader delegates the role and responsibilities as per the competence of the team members. Use effective closed loop communication. Check the equipments and supplies and ask for additional help as required. So, these are the preparation strategies for delivery. Like, do all these necessities and ask all these necessities. So these are the resuscitation supply equipments list. Okay, suction equipments, bulb, syringe, mechanical suction tubing. I just mentioned it. That's it. Don't need to remember all these things, but a few of them. Like suction equipments, a few of suction equipments, and positive pressure ventilation equipments, oxygen sources, compressed air sources, pulse oximeter, all those things, and intubator equipments, laryngoscope, extra bulbs, and battery for laryngoscope, and measuring tape, scissors, all those things. We'll move on. What is APGAR score? APGAR score is a very, very, very important topic. So, what is APGAR score? So, the objective method of evaluating the newborn's condition. It is for evaluating the newborn condition. It is not used, it is a very important thing. It is not used for guiding the resuscitation. The serial score helps in knowing how well the neonate responds to the resuscitation effort. It doesn't guide, it only evaluates. So generally performed at 1 minute. 1 minute is called as a golden minute. Okay. And again at 5 minutes after birth, before which the resuscitation is initiated. If 5 minutes APGAR score is less than 7, then extended APGAR score should be obtained every 5 minutes up to 20 minutes. So it is generally performed at 1 minute and again at 5 minutes after birth, before which the resuscitation is initiated. That is, within the 1 minute, the resuscitation is ideally should be initiated within the 1 minute of birth. And if 5 minutes APGAR score is less than 7, the APGAR score should be obtained every 5 minutes up to 20 minutes. I guess this is clear. So this is the APGAR score. So APGAR score we evaluate, that is heart rate, respiratory efforts, muscle tones, then reflex responses, and also the color. So A as for the APGAR is A as for color, that is color, appearance, that is it can be that is last one, that is color. So in APGAR the color denotes appearance, the first letter, that is A. Okay, I guess it is understanding to you all. Appearance. The APGAR score is given as 0 if the child is blue in color, that is central cyanosis or pale. And APGAR score is 1 if the body pink and extremities is blue, that is peripheral cyanosis. And it is given 2, it is completely pink. And then comes the P for pulse rate, that is heart rate. And if it is given as 0, if the heart rate is absent. If it is given as 1, it is the less than 100. If it is given as 2, it is more than 100. And G is for grimace. Grimace is reflex response. Okay, and reflex response is 0 if no response. 1 is grimace. Grimace is a crying face. And 2 if the baby cries. And then comes the A, which is for the muscle tone. So in muscle tone, that is activity. A denotes the activity. So the second A. So the muscle tone, that is flaccid, it is given as 0. Partial flexion of extremities, it is given as 1. And complete flexion or active movements, it is given as 2. And then we have the last, that is R. R is for respiratory effort. It is 0 when it is absent. Irregular or gasping respiration, the score is given as 1. And good crying, the score is given as 2. That is all about APGAR score. Please do remember this table. TABC of resuscitation. What is TABC? T for temperature, A for airway, B for breathing, and C for circulation. So this chart is very, very, very important. This is the resuscitation algorithm. So the first step, look at the first box. First is before birth, that is antenatal counseling. It is mostly done by the gynecologist. The team briefing and equipment check, and then birth occurs, right? Yes. So then after the birth, 3 questions needed to be asked. What are the 3 questions? Whether it is a term gestation or not. Whether the baby is having a good tone or not. Whether the baby is breathing or crying. If all these 3 answers is yes, stay with the mother for initial steps and routine care and ongoing evaluation. If any of the one is no, then what happens? Dry, stimulate, warm, position airways, suction if required. So then if the apnea, then again check for the heart rate and respiration. 2 things are evaluated at each steps. Okay, that is the respiration and the heart rate. So check for the apnea or gasping and also the heart rate, if it is less than 100 beats per minute or not. If the answer is no, yes, and move to the side. That is labored breathing or persistent cyanosis, if it is present or not. If it is yes, position the airway, suction if required, pulse oximeter, oxygen if required, consider CPAP, and also post-resuscitation care, team briefing. If the answer is yes, then what happens? Positive pressure ventilation is given, pulse oximeter, and consider cardiac monitoring. And you note that all these things up to here occurs in the 1 minute. That is called as a golden 1 minute. Yes. Then comes after the PPV, check again if the heart rate is less than 100 beats per minute. If it is yes, ensure adequate ventilation. Consider endotracheal tubing or laryngeal mask. Cardiac monitoring needed to be ensured. And then if at all the heart rate is less than 60 beats per minute, if it is yes, what happens? That is endotracheal tube or laryngeal mask, chest compression. Here comes the chest compression. If the heart rate, whenever the heart rate goes below 60 beats per minute, look at the chest compression. Coordinate with PPV and 100% oxygen, 100% oxygen, okay? And if at all the heart rate is less than 60, again, okay, IV epinephrine is suggested every 3 to 5 minutes. If the heart rate remains less than 60 beats per minute, consider hypovolemia or consider pneumothorax. So these are the a box on the side. It is given as the target oxygen saturation table. So first minute it is 60% to 65, and up to the 10 minutes you can see it is 85% to 95%. So this table is very important. Let us look in detail. So this is resuscitation algorithm. At the time of birth, one should ask 3 questions. We already knew that, right? Term gestation, or whether the muscle tone of the baby is good or not. The breathing or actively crying. If yes, routine care. What are the routine care? That is warmth, clearing of airway if required, dry the neonate using a dry or warm cloth, and ongoing evaluation for vital parameters. And delayed cord clamping. Why there is delayed cord clamping? The cord is clamped with a 60 seconds delay. Why? Why? Because in all neonates, preterm and term, they do not require resuscitation. Okay. Okay, if at all they do not require resuscitation, the cord clamping must be delayed by 30 to 60 seconds. That is called as delayed cord clamping. Why it is done in neonates needing, because what happens is that it increases the blood circulation. So that much time the placenta can provide the blood circulation, so thereby getting oxygen. Is that clear? Yeah, that is why we delay the cord clamping. So in neonates needing resuscitation, the clamp and clamp and cut the cord immediately and initiate resuscitation without any delay. If the answer is no, after cutting the cord, perform initial steps. What are the initial steps? That is warmth. Heat source is radiant warmer. Dry and stimulate. Pre-warmed linen. Suction and drying and tactile stimulation. We already discussed that. Positioning, that is sniffing position. Okay, sniffing position is required. Rolled blanket under the shoulder. Elevate her by 3/4 of the mattress. Clearing airway. Suction mouth before the nose to prevent aspiration. That is mouth before the nose. M before N. So that's the thing. Because there is a chance of aspiration. Catheter size is 12 or 14 gauge. Suction pressure is 80. That is not required, but initial step, you should remember the initial step. Warmth, dry and stimulate, position and clear airway if necessary. Evaluation. So next is evaluation, which is a very important thing. That is respiration. Evaluate by observing the chest movements. If it comes to the heart rate, auscultate the heart or palpate the umbilical cord pulsation for 6 seconds. Number of heartbeats or pulsation into 10 gives the heart rate per minute. And check for color, the tongue, mucous membrane and trunk. Central cyanosis, blue hue to the lip, tongue and central trunk. Acrocyanosis, that is no significance. So these things are required. Each and every step we look at the respiration and the heart rate, and also look at the color also. Good breathing efforts, that is heart rate is 100 beats per minute or more. No cyanosis, no additional intervention is needed. Okay, monitor the neonate frequently, that is the thing. And labored breathing or persistent central cyanosis if present. CPAP is in preterm neonates, and supplemental oxygen in term neonates is required. And then we have this apnea or gasping breathing, or heart rate below 100 beats per minute, provide positive pressure ventilation. So these are the three things. Supplemental oxygen mask or oxygen tube held in cupped hand over the baby's face or by a flow inflating bag and a mask. Flow oxygen at least 5 liters per minute. So this is, as you can see the figure, so this is the positive pressure ventilation, how it is given. So it is provide positive pressure ventilation with self-inflating bag and a mask. So we can see a bag and mask technique. Okay, yes, self-inflating bag is 240 to 750 ml. So you can see there is a bag, right, holding on the doctor's hand. Then connect the bag to a source of oxygen, air or blender that provides desired concentration of supplemental oxygen. Indications of PPV. So when is the PPV is indicated? When the infant is apneic or gasping, or the heart rate is below 100 beats per minute. Starting with a lower oxygen concentration prevents the harm of hypoxia. So always start with a lower concentration. Do not just immediately give 100% oxygen and all. Always start with a lower concentration, which prevents the harm of hyperoxia, like bronchopulmonary dysplasia or retinopathy of prematurity. Monitor oxygen saturation, pulse oximeter, and titrate oxygen concentration to maintain oxygen saturation. So PPV, the term neonates, the resuscitation with room air is effective as compared to 100% oxygen in the case of term neonates. In the case of preterm neonates, less than 35 weeks of gestation, start resuscitation with 21 to 30% of oxygen, followed by or up or downward titration based upon the pulse oximeter. So, if at all, usually the neonate responds to the positive pressure ventilation after the birth, which with an immediate increase in their heart rate. If the neonate is not responding by a rapid increase in the heart rate after 15 seconds of PPV, assess chest movements and auscultate for breath sounds. If it is no, take a ventilation corrective steps, that is MR SOPA. So, what is MR SOPA? MR SOPA is for correcting the PPV. If at all the heart rate is not going beyond 60 or it is not going beyond 100, we need to correct the steps which we have done earlier. So that is M for mask reapply. MR mask reapply, reposition the head, and S for suction airway with bulb syringe, and like O for open the mouth, like whether there is an obstruction or anything, and increase the PIP to maximum of, that is P for pressure, of 40 centimeter H2O, and next is A, that is alternative airway. So there is MR SOPA, mask reapply, just replace the mask with any other or reapply the mask, and then reposition the head, and suction airway with bulb syringe. O for open the mouth and look, and next is pressure, and also that A is for alternative airway, that is endotracheal tube intubation or all those things. Yes, then endotracheal intubation indications. What are the indications for EDT? So that is, if the neonate's heart rate is less than 100 beats per minute despite 30 seconds of effective PPV, when prolonged bag and mask ventilation is required, when bag and mask ventilation is ineffective, when chest compression is needed, suspecting diaphragmatic hernia, or when the airway is blocked with thick secretions. So diaphragmatic hernia is a condition, it is a contraindication of PPV. Then ET intubation for administering epinephrine. So this is endotracheal tube. Chest compressions. Chest compression, we already learned that chest compression is initiated if the heart rate is below 60 beats per minute, right? Yes. Chest compression helps mechanically pump the blood into the vital organs of the body. Chest compression consists of rhythmic sternum compressions that compresses the heart against the spine, which increases the intrathoracic pressure and circulates the blood into the baby's vital organs. And bag and mask ventilation must always accompany the chest compression, so only oxygenated blood is circulated during the chest compression. So, what are the indication we already talked about? That is, heart rate is less than 60 beats per minute even after 30 seconds of PPV. And once the heart rate is 60 beats per minute or more, the chest compression should be discontinued. And what is the procedure? Two-thumb technique. Two thumbs depress the sternum with the hand encircling the torso and the fingers supporting the back. The pressure lower third of the sternum. Complications, that is broken ribs and laceration of the liver and pneumothorax. These are the complications. Rate. So rate is a very important thing to be learned. What about the rate? The ventilate between chest compressions. That is, a positive pressure ventilation is given every third of chest compression, that is 90 chest compression and 30 PPV, that is 3:1 ratio, 3 chest compression and 1 PPV. Okay, so 90 plus 30, that is 120 events takes place in 1 minute. I guess you got it. So then comes the evaluation. After 60 seconds of chest compression, check for heart rate. Heart rate, if it is below 60, continue chest compression with PPV plus medication, that is epinephrine. If the chest compression is the heart rate is 60 or above, discontinue chest compression. PPV must be continued until the heart rate is above 100 beats per minute and the infant breathes spontaneously. So medications. The last thing is medications. Coming to the medications are delivered through the umbilical vein. For umbilical vein access, insert a 3.5 or a 5 umbilical catheter into gauge umbilical catheter into the umbilical vein. In an emergency, epinephrine can be delivered through the trachea if intubated, only if venous access cannot be obtained. Drug injected by a syringe or a feeding tube to the ET tube and dispersed into the lung by PPV. So this is the medication, that is epinephrine, and concentration 1 is to 1000. Indication of heart rate is less than 60 beats per minute. After 60 seconds of effective PPV and chest compression. So effects is inotropic effect, chronotropic effect, and peripheral vasoconstriction. And this is concentration administered is 1 is to 10,000. Dose of prepared solution is 0.2 ml per kg. Route is IV. Normal saline or ringer lactate, acute bleeding with hypovolemia, increased intravascular volume improves perfusion, and this dose is 10 ml per kg and through the umbilical vein. So this is table from APGAR, yeah, from pediatric textbook. So this concentration and dosage route all are very important. So reference is this. Thank you.